Hello, good evening, friends.
Hello, good evening, everyone. At the outset, I would like to thank Ajanta Pharmaceuticals for organizing this webinar. And I would like to start this webinar by introducing my very respected sir and colleague, Dr. Shobhit Kakkar. A brief introduction about him, I would like to give all the viewers about him is that he was awarded a gold medal for best student in MS ophthalmology at KGMU Lucknow in the year 2000, and he completed his fellowship in vitro retina from Retina Foundation, Ahmedabad, under the supervision of Professor P.N. Nagpal, sir. He's into private clinical practice at Vision, the Eye and Retina Care Center at Lucknow since July 2002. He's been practicing both anterior and posterior segment with special interest in managing complicated cases of diabetic retinopathy as well as retinal detachment surgeries. This is a brief introduction for Sir, and now I would like to hand over the session to Sir so that he can present his webinar. Thank you.
Thank you, Dr. Jimmy. And at the outset, I'll again thank Ajanta Pharma for giving for sharing my presentation and views on diabetic retinopathy. So today we will be discussing the presentation of diabetic eye disease, the presentation, classification, investigations, and management. To begin with, the diabetic eye disease not only involves the retina, it can cause cataract, glaucoma, retinopathy, definitely optic neuropathy, and also the neuropathy involving the ocular muscles. The presentations could be varied of diabetic effects on the eye. They could be causing a frequent change in the power of the spectacles, producing floaters in the eyes, causing a diminution of vision with glares and halos, the presence of a black spot floating in the field of vision, metamorphopsias, or at times pain, redness, and in extreme cases, loss of vision also. So basically, the diabetic retinopathy is a microangiopathy which affects the small-sized capillaries to begin with. And in long-standing diseases of diabetes, usually more than 5 years of duration, contributes about 5% of the total cases of blindness in the world. And the retinopathy occurs in about 30% of patients who are older than 40 years of age. The retinopathy occurs earlier in patients of insulin-dependent diabetic maculopathy as compared to the patients of non-insulin dependent diabetic maculopathy. But the prevalence of the disease is much more in the non-insulin dependent because the total number of patients of non-insulin dependent are much higher. The ratio of blindness between non-insulin dependent and insulin dependent is 1:2, meaning that insulin dependent retinopathy is more severe and progresses faster and has more severe manifestations. The role of antioxidants is a supportive role. It can decrease the oxidative stress and the cell apoptosis. And mainly the antioxidants consist of the carotenoids and melatonin. What are the risk factors of diabetic retinopathy? Like we feel that these patients would have a higher chance of developing the disease, which is the age at the time of diagnosis, the duration of the disease. Greater is the duration, the greater are the chances for the retinopathy to occur. Poor control patients have a higher chance. If there is coexisting hypertension, involvement of the kidneys, hyperlipidemia, presence of low hemoglobin levels, then definitely the chances of retinopathy are greater and the progression is also faster. And if the patient is a smoker, is having obesity, or there is presence of pregnancy, then because of hormonal changes, the diabetic retinopathy occurs earlier. The mechanism of damages, it involves basically initially the pericytes or the supporting cells of the blood capillaries and the endothelial cells. As the disease progresses, there is narrowing of the lumen of the retinal arteries. The area available for the flow of blood decreases. There's a formation of microaneurysms because of the loss of the pericytes, and there is an increase in the intraluminal pressure. Occurrence of the looping of the vessels to accommodate more blood as the walls have already become weak. There's a disruption of the blood retinal barrier causing the oozing of fluid out of the blood vessels into the retinal tissue. And in the more advanced cases, as the capillaries get blocked, there are areas of capillary non-perfusion, and finally the formation of neovascularization. As you all know, the ETDRS has classified diabetic retinopathy into the non-proliferative and the proliferative type. The non-proliferative is further divided into mild, moderate, severe, and very severe, and the proliferative is divided into early and high risk. The mild non-proliferative type is basically classified depending on the comparison of the patient's retina with a standard photograph in which there are presence of microaneurysms. So if the presence of microaneurysms and hemorrhages are less than the standard photo 2A, which was a specified photo used in the ETDRS classification, then it is termed as mild NPDR. In cases of moderate NPDR, the hemorrhages and the microaneurysms are more than the standard photograph 2A. There could be presence of the cotton wool spots, presence of venous bleeding, intraretinal microvascular abnormalities. Yet the features are not that advanced that the criteria of severe or very severe NPDR is met. As in these photographs, you can see that there is this presence of hemorrhages, there is presence of exudates, there is presence of cotton wool spots here. In severe NPDR, the hemorrhages and the microaneurysms are again more than the standard photograph. There is the presence of venous bleeding, there is presence of intraretinal microvascular anomalies. So these patients will be termed as severe NPDR. And in very severe, if any two or more of the changes seen in severe are met with, then it becomes a very severe NPDR, and there should be absence of any proliferative changes. As you can see, these angiograms, there's the presence of looping is there, there's presence of the new blood vessel formation over here, which is showing leakages at multiple points, the areas of capillary non-perfusion, there are areas of beading of the blood vessels. So this is a patient of early proliferative diabetic retinopathy. And then the high-risk patients of PDR are those which include any one of the following criteria. If the neovascularization of the disc is more than 1/3 to 1/4 of the disc diameter, or it's less than 1/3 to 1/4 of the disc diameter with the presence of vitreous preretinal hemorrhages, or there's presence of NVE with vitreous of preretinal hemorrhages. For example, in this case, there's presence of NVE and there's a large preretinal hemorrhage. So this becomes automatically a case of high-risk proliferative diabetic retinopathy. The diabetic macular edema has also been classified into 4 different types. It could be a focal edema in which there are few leaking microaneurysms, whereas the rest of the macular area appears to be relatively normal. It could be the ischemic type when there's a gross loss of the capillaries in the macular area, and it could be the diffuse type in which there is extravasation of the fluid over the whole of the posterior pole. You can't find any clear pinpoint leaking areas, or it could be the mixed type. Most of the times you usually find the mixed type with a combination of a focal edema, ischemic, and diffuse both. We have all learned what actually the clinically significant macular edema implies. It is the presence of a retinal edema within 500 microns from the center of the fovea, or the presence of hard exudates within the 500 microns from the center of the fovea, or a large area of retinal edema, any part of which is within 1 disc diameter radius from the center of the fovea. Now, these are a few slides, the fundus photographs, the OCTs, and the angiographies to show the various types of presentations. This OCT picture is showing you a cystic type of appearance, large cystic spaces, the gross thickening of the various layers of the retina. And on doing an angiography, this is the early phase and this is the late phase, you find these multiple microaneurysms with leakages which are visible in the later stages. The severe exudative edematous type of diabetic macular edema is visible over here. And this is a fundus photograph showing you a large chunk of exudates with hemorrhages. And on doing an angiography, you find that there are areas of capillary dropouts in this area here. Plus, there are areas of larger capillary dropouts. And on doing an OCT, you find there's a extensive exudation. There's presence of lipid material in the form of deposits within the layers of the retina. At times, you can also find that there is a sort of a tractional element involving the foveal area, leading to a foveal detachment. The fovea is being pulled by this taut posterior hyaloid. It's causing a pucker and pulling it upwards, lifting the inner layers of the retina, leading to a detachment over here. This is the advantage of the OCT. By simply looking at the fundus photograph or by doing an angiography, we will not be able to pick up this, and hence OCT is also needed simultaneously to make a complete and accurate diagnosis and plan the treatment protocol. Other cases of diabetic maculopathy, this is a circinate ring of exudates. These are microorganisms which are showing leakages over here and here also. And these are again multiple ones. This is the left eye, and the right eye is also showing a similar picture. Extensive exudation. These are the patients whom you should suspect that they are either having hyperlipidemia or nephropathy. Because if there is extensive exudation, then these two features have to be looked for. Look for the systemic parameters. As another type of presentation, there's the presence of pre-retinal hemorrhage, indicating that there has to be some element of neovascularization either behind this pre-retinal hemorrhage or neighboring areas. And on doing an angiography, it's confirmed that the neighboring area has this NVE showing leakages. And then there's a macular edema. By looking just at the fundus photograph, the macula looks relatively healthy, but when you do an angiography, then you have the typical flower petal appearance diagnostic for the macular edema, and it is extensive. So here comes the importance of doing an angiography also. So you have to do an angiography, you have to do an OCT, and you have to do angiography to view the peripheral areas also. This is when advanced cases of proliferative diabetic retinopathy showing looping of the vessels, extensive NVE, there's presence of pre-retinal hemorrhages, subhyaloid hemorrhage, vitreous hemorrhage, all mixed types of presentation. Large areas of non-perfusion visible over here in the periphery. Another presentation is showing a lot of fibrotic changes here, a lot of NVE areas, multiple NVE areas here in this fundus photograph. And on doing an angiography, you see that the foveal avascular zone is grossly enlarged in size. So these are the patients, no matter how well you treat them, no matter the edema subsides, but the visual recovery will not be very good because the macula is already ischemic. In the last 5 to 7 years, we have again realized the importance of doing a ultra wide field angiography, meaning that we have to visualize the areas beyond the equator more anteriorly, the peripheral areas close to the aura, because at times these are the areas which we were not able to visualize with the initial angiography machines that we had. And these are the areas which were having the pathological changes which could not be detected. Now there are these ultra-wide field angiography machines that are available. There's Spectralis, there's Zeiss, Claris 700 and Optos, which give a excellent viewing capabilities, showing areas of NBE in the periphery, non-perfusion areas. So we can plan our treatment much better and prevent further visual losses. Now coming to the OCT angiography, the basis of doing OCT angiography is that the laser light reflectance is occurring from the surface of the moving red blood cells, and a large number of A scans are taken at very rapid successions, and depending on the difference in the reflectance between the simultaneous A scans, you determine the movement of the red blood cells. The amplitude of the transmitted and the reflected light is measured, and the phase difference of the wave pattern of the transmitted and the reflected light is measured. That is the basis of the OCT angiography. It has definitely certain advantages over a conventional fundus fluorescein angiography. First being it's non-invasive, it's fast, it's safe, and no chances of any anaphylactic reaction occurring to the dye fluorescein. It is easily repeatable, and you are able to see the various layers of the retina end phase layer by layer. The two types of OCT angiographies are available. One is the spectral domain and the other is the swept source. The spectral domain is the older version and the swept source is the relatively newer version. The swept source one has a better resolution. It has a greater number of A scans that can be performed in unit time, and it gives you better information because it has better light penetration to the retinal pigment epithelium. Hence, it is also useful for determining and visualizing certain choroidal lesions. As the experience with the usage of OCT angiography is increasing, we are finding it that it is corresponding to the results of doing a conventional FFA. On the left is the conventional FFA photograph, and on the right is the OCT angiogram. And you can see that fairly you get similar results. There's areas of NVE leakage is being visible here, but in the OCT angiograph, since no dye is being injected, so apparent leakage will not be visible. But you know that there's a cluster of vessels which is abnormal, and this is the NVE. It is also useful for monitoring the response to the treatment without repeatedly injecting the dye and doing invasive procedures. The top photographs are pre-treatment, and following treatment, there is a resolution of the neovascularization of the disc. On the other hand, you can also monitor progression. If the treatment response is not satisfactory, the neovascularization has markedly increased. It's become more florid. And with the newer softwares available with the swept source OCT angiogram, you are able to create a montage field by combining the pictures of taken in various segments. As our experience with the OCT angiogram is increasing, we are now able to use newer terminologies to ascertain the findings, and one of these is the suspended scattered particles in motion in patients of diabetic retinopathy. These are basically extravascular OCT signals which correspond to the hyperreflective intraretinal fluid or lipid material which is leaked out of the blood vessels into the layers of the retina over here. And this gives us an objective way of labeling the capillary perfusion density in a numerical form. You are able to detect that what is the number of the capillaries in a limited area, and depending on the losses of capillaries, the color grading is done. Red are those areas where there are large extensive losses of capillaries, and yellow is there's minimal loss. You can also do certain mathematical calculations determining the area of the foveal avascular zone, its perimeter, and its diameter. This, based on the digital subtraction OCT angiography, you are able to determine how much the FAZ is abnormal as compared to the normal patients. These photographs, the top three are the controls, and this middle and the lower ones are of the patient. In the middle line, you will see that there's a loss of capillaries in the center area, which is shown by these red areas. Red indicates that there is a gross dropout of the capillaries, and yellow indicates there is lesser dropout capillaries. Here you see there are lesser dropouts, and this is the area where there are more dropouts. And in the bottom line, this is of another patient in which the central area of the foveal avascular zone is relatively normal, but the areas adjoining it, there's a lot of capillary dropouts. Again, the red area indicates gross losses, and the yellow areas indicate lesser subtle losses. Before you start the treatment of patients suffering from diabetic retinopathy, it is important to determine what is the systemic status of the patient, what is the ocular findings of the patient. So for these tests are mandatory, including the blood pressure, the hemogram, sugars, HbA1cs, the kidney function tests, the cholesterol levels, the urine evaluation, and nerve conduction studies in certain patients. The ocular tests like the angiography, OCT angio, and a B-scan ultrasonography if there is a presence of vitreous hemorrhage which is masking the appearance of the retina. Now coming to the treatment, basically we have to treat on these four major guidelines. First and foremost, you have to improve the oxygenation of the retinal tissue. How do we improve the oxygenation? You treat the anemia so that the oxygen supplying capacity of the blood becomes better. You have to treat nephropathy, hypertension, and lipidemia because all these three are ultimately reducing the lumen, the size available for the carrying of the blood. You can surgically induce posterior vitreous detachment by doing a pars plana vitrectomy because then that improves the oxygenation from the side of the vitreous. Or you can create multiple micro PVDs by doing laser PRP, pan-retinal photocoagulation. The second step, which is in the aim of treatment, is to redirect the blood from the non-vital peripheral hypoxic areas to the vital central hypoxic areas. If you have limited resources, then you need to use them in the areas which are vital for the vision, so that you do a laser PRP in the peripheral areas because that is the area which you can compromise without any loss of the central vision because that is what is more important. The third aim of treatment is to decrease the edema and inflammation of the retina because this is what is going to improve the central vision dramatically. And for that, you have the options of using a focal laser, anti-VEGF injections, or steroid implants, posterior subtenon injections. And in advanced cases, if there are the presence of tractions and proliferations or presence of vitreous hemorrhage, then in all these patients, you need to do a pars plana vitrectomy. So now let's plan the treatment for a patient who has an involvement predominantly of the posterior pole and with the second group of patients who have involvement of the central as well as the peripheral retina. If predominantly the posterior pole and the macular area is involved and the focal edema is there with microaneurysms at the fovea. So in these patients, focal laser is not possible because you will be destroying the vital photoreceptor cells close to the fovea. So these are the patients in which anti-VEGF injections would be useful. However, if the leaking microaneurysms are away from the fovea, extrafoveal, then such patients, and there are limited microaneurysms, there is no diffuse macular edema, then focal laser will work in such patients. And if there is diffuse or mixed edema, then again you would be needing anti-VEGF injections combined with a grid laser. Ozurdex can be supplemented if the macular edema persists, but initially it is always better to use an anti-VEGF before going in directly for an Ozurdex. If the central and the peripheral areas both are involved, then again the focal edema with microaneurysms at the fovea and CNP areas, NV, you need to use an anti-VEGF injection with laser photocoagulation, PRPs. If there is focal edema with microaneurysms which are extrafoveal and there are no CNP areas, meaning that the macula is involved, but the involvement is extrafoveal, leaking microaneurysms, and there are no apparent NVE or NVD, then in such patients, you can do a laser focal and PRP to treat. However, if there is the presence of neovascularization, then in such patients, you need to use an anti-VEGF injection plus laser. Various intravitreal drugs are available. To begin with, we had the option of bevacizumab, later on ranibizumab, aflibercept came, and triamcinolone is the old drug, and then you have the options of a dexamethasone implant, Ozurdex. So these are the ammunitions available in our armamentarium for the intravitreal injections of varying doses. They have their benefits, they have certain disadvantages. First and foremost, before you plan to give an intravitreal injection, it is always better to take an informed consent, meaning you advise the patient, tell him of his status, what is he suffering from, what is the condition of the retina, what is the condition of the macula, how do you plan to treat, what do you expect out of this treatment, and be clear cut. Don't make him feel that his vision is going to improve dramatically. You have to tell him the exact picture. And if you are planning to use Avastin, then you have to tell of the off-label use. There are Possibilities of thromboembolic event. So you have to take a detailed history. The systemic parameters have to be monitored. Take the history of any cerebrovascular accidents, any heart-related problems, and if present, then avoid use Avastin. In patients whom you plan to use Ozurdex, there is always a possibility that after the injecting Ozurdex implant, the intraocular pressure can go up. So if there are chances of a pre-existing raised IOP, or there is a presence of a family history positive, then you might think of avoiding its use. And similarly, for injection triamcinolone, there is a possibility of again causing an increase in the intraocular pressure and cataract. The AIUS and the Vitreoretinal Society of India has issued these forms for taking the informed consent. These are available on the websites. Most of us, I think, should be using it. If not, then you can go to the website and download it. You first have to control the systemic and the metabolic parameters. These are of paramount importance. Don't jump directly to the treatment of the retina itself, because you know that retina has been affected because of a systemic disease. Unless you don't treat the main disease, no matter how good treatment or how meticulously the patient comes for his follow-up visits and gets treatment done, long-term effects will not be there. So if any of these parameters are out of control, treat them. Then you have to do a retinal laser photocoagulation or an intravitreal injection. And if needed, in severe cases, you can go in for an intravitreal steroid implants. And finally, there's an option of surgery. I just wanted to show a short video of giving the anti-VEGF injection. Measure the area which you want to give, whether it's 3 millimeters, 3.5 or 4, depending on the lens status of the patient. You can apply a paracaine dipped swab for local anesthesia and gently stabilize the globe and inject the needle. Visualize the tip of the needle inside behind the lens and then gradually inject it. The tip of the needle should be directed towards the center of the globe. Avoid touching the lens. For the Ozurdex injection, it is important that you do a bilaminar or a trilaminar insertion because it's a thick bore needle. So you go a partial thickness into the sclera and then go perpendicularly inside. In advanced cases, at times it is needed to use anti-VEGFs and Ozurdex injections simultaneously, but that's very rare and I always prefer to avoid it. However, if the need arises that you have to use both of them, then it is always better that first you inject the anti-VEGF and then the Ozurdex implant later on. The reason being that if you inject the Ozurdex implant before and you inject the anti-VEGF injection later on, then the stream of the anti-VEGF injection at times might displace the Ozurdex into the visual axis and it can damage the retina or the macular area. Certain differences between bevacizumab and ranibizumab. As you all know, ranibizumab has a lesser half-life and its clearance is faster as compared to bevacizumab. And ranibizumab is more expensive, reason being that responses are slightly better as per some studies, and it has a higher affinity to block the VEGF. You also have to keep in mind certain contraindications for anti-VEGFs, as I have already mentioned earlier: presence of stroke, cardiac arrests, uncontrolled hypertension or diabetic. If the patient is on anticoagulants, there is presence of active inflammation of the eye or the periocular tissue, or there is presence of fibrovascular proliferations, which can threaten the macula and produce a tractional retinal detachment. Because once the edema subsides after the usage of these injections and the retina, which was elevated, tends to go back and to its normal position, the tractions are going to be stretched and they may cause damage. In the presence of active tractions projecting into the vitreous cavity, it should be used with caution and if possible avoided. And if there is any type of hypersensitivity in the past to these injections, then they should be avoided. These are certain pre and post-treatment photographs. A patient who had come with a focal edema on OCT, you're seeing that these are the areas, cystic changes here. And following laser treatment done to these leaking microaneurysms, the resolution of the heart exudates has occurred and the contour of the retina has normalized. These are patients of diabetic macular edema with a lot of fibrin deposits because the systemic parameters were uncontrolled. So following the control of the systemic parameters and giving an anti-VEGF injection, this was the response after 2 injections. There's still some fluid, subretinal, submacular area, there's fluid. So a repeat injection would be needed, followed by a pan-retinal photocoagulation. Again, these are the patients, like I told, where you feel that the macular area, the foveal area is relatively safe. The leaking aneurysms are away from the center portion. There is no NBE. So these are the patients who can do well with just a laser treatment. There are certain patients in which there is foveal detachment, and you can see there is a lot of fluid accumulated in the macular area. And these are the patients in which there is less of an ischemic element and more of an inflammatory element. So naturally, if there is a more of an inflammatory element, then the intravitreal steroid implants would be better in such patients. This is a pre and post-treatment photograph of the central serous macular edema who has been treated by giving an injection and grid laser. This photographs on the left side are pre-treatment, these are post-treatment. The cystic spaces have resolved dramatically, a few areas persist. These are the OCT pictures, pre-treatment and post-treatment. This patient was given an anti-VEGF injection. This is it following 2 injections. Again, you feel that there's a residual edema. So don't hesitate to give a 3rd injection in such patients, followed by laser if you are sure that the microaneurysms are there and they are leaking. Another patient, you see that there's a gross thickening of the retina. It's almost 450 to 500 microns in the center area. And following treatment, there's a resolution of the subretinal fluid. The retinal contour normalizes, the thickness comes back to normal. And the vision in this case, which was around 636, improves to about 612. Again, a patient of cystic macular edema with large spaces. He was given intravitreal anti-VEGF injections, 3 doses, and following the 3 injections, the vision improved to about 6/9. Now coming to the role of surgery in patients of diabetic retinopathy, what are the indications? If there's the presence of recurrent vitreous hemorrhage in a laser regressed PDR, meaning the laser was given adequately, the diabetic retinopathy regressed, but despite that, there is recurrent vitreous hemorrhages, indicating that there is some form of traction onto the new vessels which is producing this recurrent hemorrhage. There is presence of secondary rhegmatogenous retinal detachment, or there could be presence of a tractional ailment at the macula with ischemia or without. This is the presence of posterior pole tractional retinal detachment, or there is a TRD involving the upper half of the retina. Premacular fibrosis, presence of retinal wrinkling, large pre-retinal hemorrhages obscuring the macular area. These are the patients in which past retinal vitrectomy might be useful, or you can avoid it. This depends on the discretion of the surgeon. If there is florid neovascularization with or without any of the above indications, there is presence of anterior segment neovascularization, or neovascularization which is not responding to lasers with or without any of these above indications, or large non-resolving vitreous bleeds, because such are the patients in which the macula is already grossly damaged and chances of visual recovery would be limited. And these are the indications in which you would definitely not like to do a past retinal vitrectomy. If there is inferior peripheral TRD, it is not going to compromise the central vision. There is recurrent vitreous hemorrhage in an active PDR. So in these patients, maybe you need to give a repeat anti-VEGF injection, do a little bit of more laser augmentation. And if there's presence of macular tractions, but there's a gross ischemia, there's a large FAZ, then these patients will not benefit. The goals of doing a pars plana vitrectomy is you have to clean the vitreous hemorrhage, you have to induce a PVD, as I had mentioned in the earlier slides, to improve the oxygenation of the retinal tissue from the side of the vitreous. Remove the presence of any epiretinal membranes that are present. Do a good laser photocoagulation with or without an anti-VEGF injection. And at the same time, you have to prevent the iatrogenic per-operative breaks. And if they occur, then you have to use silicone oil. It's always better to use a lot of caution because you don't want to use silicone oil in such patients in which the oxygenation is already compromised. Because in the compromised oxygenation, if you put silicone oil, then there's further going to induce hypoxia. A lot of innovations in the instrumentation and equipments have occurred in the last 10 to 15 years, which has made the vitrectomy faster, safer, and better. There's the presence of a wide-angle viewing system, contact high magnification viewing lenses, high-speed vitrectomy cutters, narrow-gauge vitrectomy cutters in which the bore is much closer to the tip so that you can go very close to the retina and do a lot of work for which we were initially using intravitreal scissors and forceps. Now with the help of these 25 gauge and 27 gauge vitrectomy cutters, most of the work can be done. The presence of valved trocar cannula systems has been of great help because they do not allow the egress of the fluid when we are changing the instruments or the light pipes. As a result of this, the intraocular pressure remains stabilized throughout the surgery, and there are lesser chances of inducing entry of infective material inside the eye. Minimally invasive vitrectomy surgery instrumentations have increased. Various types of forceps, end gripping, and various types of scissors, scrapers, chandelier light sources, xenon and LED light sources, various types of laser probes and light probes which are curved, angled, so that you can do a good visualization and good laser photocoagulation of the peripheral parts of the retina. Presence of staining dyes by which you can stain the vitreous by using such triamcinolone. You can stain the posterior hyaloid, you can stain the internal limiting membranes. And now, of late, last 2 to 3 years, there's a heads-up surgery of Ingenuity and Artivo, in which you get a extremely good 3D perception in a large magnified view. So precision of surgery can improve. And plus, with these symptoms, there is the option of a per-operative OCT angiography. So you are able to determine whether, suppose you are doing a membrane peeling, whether the membrane peeling has been removed completely, if there is presence of the tractions or the stria at the macula, whether they have been eliminated. Coming to a few videos I would like to share of pars plana vitrectomy in a diabetic patient. Once the posterior vitreous detachment has been introduced, you try to remove all these thick posterior hyaloid and these fibrovascular proliferations, because these are the culprits for producing these recurrent bleeds. And if you find that there is a taut fibrovascular proliferation adhering to the retina at two places, do a segmentation, means cut it in the center and try to trim off as much as possible, but be careful not to create iatrogenic breaks. However, at times, if there are multiple points of adhesions of these fibrovascular proliferations to the retina, then you would need to use a bimanual technique. In such patients, you use a chandelier light system and you use two instruments, one forceps and one scissors. Forceps to pull the fibrovascular sheet upwards and determine the places of adhesion and gradually cut through these areas. This is a delamination process which is being done. Multiple adhesions to the surface of the retina. You're using a scissors to trim out all these adhesions between the fibrovascular tissue and the surface of the retina. You need to pull gently because the tissue is friable and there are chances that iatrogenic breaks can occur. Once it has been removed, then you can eat up these fibrovascular elements with the vitreous cutters. And I found that this was too tightly adherent, so it is better that you leave these. It's not going to do any harm. Rather than creating a retinal break and then you need to put an oil inside. And following the vitrectomy, it's always advisable to look for peripheral breaks by doing an indentation of the anterior parts. You can shave off the base of the vitreous to minimize the chances of tractions and recurrent bleeds occurring. And finally, do an adequate laser. This is a patient who had a large pre-retinal hemorrhage. So you need to induce a posterior vitreous detachment. Once that has been done, then the blood that is collected behind the posterior hyaloid, it's easy to remove. Luckily, the patient had a nice healthy macula and was able to regain good vision. See, because the tip of the bore of the cutters is very close to the tip, so you can go very close to the retina and try to remove these vitreous strands and the proliferations along with it. The trick is to create a good posterior vitreous detachment. One of the last videos. Here's was a very taut posterior hyaloid. Along with this, there were a lot of fibrovascular proliferations which were bleeding during the surgery. So in these patients, it is at times needed that you raise the bottle height, increase the intraocular pressure. And most of the times you're able to get out of it. They come out in the form of sheets. This is a thick hyaloid. Because if you don't remove the posterior hyaloid, then it will act as a scaffold for the development of new vessels in the near future. And again, the purpose of doing a vitrectomy would be lost because then recurrent vitreous hemorrhage will again occur. So to conclude, the anti-VEGF therapy has been a boon for treating the patients of diabetic retinopathy. The role of laser photocoagulation is still relevant. It's not that laser is to be locked and kept away. Surgery is reserved for the vitreomacular tractions in advanced cases of proliferative retinopathy with vitreopathies. A good metabolic control of sugar and other systemic parameters is vital for the holistic treatment, and prevention and screening are the keys. The All India Ophthalmic Society has been conducting the Stop Blindness Jyot Se Jyot Jalao program. It's a screening program to determine the new patients of diabetes and presence of diabetic retinopathy. And the best way to decrease the load of this disease is you need to educate the patient. You need to coordinate with the physicians so that they are able to refer the diabetic patients to you timely so that they can be screened. The paramedical staff needs to be trained so that they can be sent to the rural areas, do a large-scale screenings, and pan-India screening, what our organization is already doing. With that, I conclude my presentation. Thank you very much.
Okay, thank you, sir, for the illuminating and a very elaborative talk on the pathogenesis and management of diabetic retinopathy. I'm sure the videos were very wonderful and the viewers must have gained a lot. And we have a few questions coming up for you. Should I start the questions and answer session round, sir?
Yeah, sure.
Yeah. So the first question asks is that what antioxidants are really helpful in management of diabetic retinopathy, and if so, which antioxidants would you recommend?
The antioxidants are having a supportive role only. They're basically the free oxygen radicals that are accumulated in the body, the oxidative stress that is occurring, they tend to neutralize that. So predominantly the antioxidants which have a higher capacity to neutralize these oxygen radicals, that is astaxanthin, is found to be more potent as compared to lutein and zeaxanthin. And plus there is role of melatonin. These are the things which you can use. Okay, but these are not wonder drugs. These are only supporting the treatment.
Right.
So don't expect that by just giving the antioxidants, the vision of the patient is going to improve. I don't think so.
Okay. So the next question is any recommendation of Ozurdex as you discussed? He would like to like just revise the indications of using Ozurdex.
The Ozurdex is to be used in patients under two conditions. In the first case, there could be a patient who is having a diffuse macular edema. Once the systemic parameters have been normalized, you have given an anti-VEGF injection, you have done adequate laser. Despite that, there is the presence of macular edema. It is not responding to further treatment. In those patients, you assume that there is an inflammatory component which is there. There's presence of inflammatory mediators which have not been completely neutralized. In these patients, yes, Ozurdex can have a role. The other option is that if at the time of presentation itself, you find that the blood supply to the macular area and to the peripheral and the equatorial areas is not compromised to that much of extent, yet the patient is having significant macular edema. So these are the patients where you suspect that inflammation is a predominant etiology for the macular edema. In these patients, again, you can think of using an Ozurdex implant.
Right, sir.
Otherwise, if you feel that there is, or you see that there is presence of inflammation as well as neovascularization, in such patients, I would always prefer to treat with an anti-VEGF first, decrease the inflammatory element because anti-VEGF also have a component of anti-inflammatory decrease. Plus, you get the benefit that there's a retraction of the retinal blood vessels, the VEGF load decreases in the eye. And even after using 3 or 4 doses of anti-VEGF, if you need, then Ozurdex can be used.
Right, sir. So what is the role of calcium globulate in the management of diabetic retinopathy?
It doesn't have much role. It was a drug which was used previously about 15-20 years back, but of late, I don't think people are using it. It had, people were telling in the stabilization of the vessels of the blood, but I have not found it to be used.
Okay. So Dr. M.R. Jain asks, any correlation of HB1AC? How do we does it require repeated measurements and the modulation of the treatment accordingly?
Yes, definitely. Because what happens is that sometimes if you have done an adequate treatment and you call, okay, you have done an adequate treatment and you call the patient after about 3 months for a regular follow-up visit, and all of a sudden you find that the retinopathy has worsened. The patient comes and with a blood sugar report. The doctor, I have done my blood sugar about 4 days back. The blood sugar reports are say fasting 125, BP 180. So that report is not too bad. So you would think that why has the retinopathy progressed? But if you get an HbA1c, because that is fasting and PP is telling you that point of blood sugar levels. Whereas what was the results in the last 3 months, 90 days, the period value will be evaluated by the HbA1c. So if that is coming out to be 8.5 or 9, then you know that the parameters are out of range, and that is the reason for the progression of the retinopathy.
Right.
That thing helps. And plus it is always advisable that for monitoring purposes, fasting and PP has a limited role. I would always like to get an HbA1c done maybe after every 4 to 5 months.
Okay, sir. So any efficacy of biosimilars like Zybev, bevacizumab by Zydus, which has come up?
Yeah, they are doing decent because see, basically the active molecule remains the same. They have just done some modifications in the side chains because of the
Okay.
patency issues. So efficacy wise, they are comparable to the parent drug, be it Zybev by Zydus or Razumab by Intas. Both of them have quite good efficacy. Initially, there was some problems with Razumab. Those were because of the they were producing some sterile endophthalmitis. This was because of the protein chains. They were producing certain reactions in the body.
Right.
But of late, now
The
for the
next
last
question is like, can you discuss the measurement of foveal?
measurement of fovea.
Yes, foveal avascular zone on FFA. When do we say it is definitely enlarged or irregular shape is more important? Is thinning on OCT also suggestive of ischemia?
Thinning of OCT will not be indicative of ischemia because thinning of OCT can be found in multiple other diseases. But as regards the foveal avascular zone, if it is more than 550 to 600, people are at times say 700, then definitely it's on the higher side.
Okay. So one interesting question is, should extra precautions to be taken during investigations and treatment of diabetic retinopathy patients during the COVID era? Any significance or relevance in the COVID era as far as diabetic management is concerned?
Uh, See, you need to give a lot of importance to the other parameters also because of late, if atypical presentations of COVID patients has come, there are patients who have presented with a decrease in the platelet counts and ischemias, petechial hemorrhages on the skin surfaces also. So, if you are treating a diabetic patient in COVID area, you have to assume that any patient coming to you could be COVID positive, coronavirus positive. So, you have to do an entire set of investigations before you start the treatment to ensure the safety of yourself also.
Okay, so and the last question is, when would we repeat an FFA in a treated PDR patient in follow-up period? What will be the follow-up period for such patients who are treated and we want to further investigate or see?
See, if the patient is stable after you have done a treatment and the vision is stable, his metabolic parameters are stable, then maybe you can avoid doing a fundus fluorescein angiography and just monitor it by doing an OCT. However, if you are feeling that the metabolic parameters are out of control, the patient is complaining of a few floaters which were not there initially, it could be presence of a minute bleed. And a minute bleed, such floaters should not be ignored in these patients. They could be indicating that there is a likelihood of a greater intensity vitreous hemorrhage or a pre-retinal hemorrhage occurring in the near future. So if the patient who has been treated adequately complains of fresh vitreous floaters or the metabolic parameters are out of normal, then yes, definitely you go ahead and do an angiography because you need to determine what is the level of the ischias in the periphery, whether any new vessels are developing.
So we are done with the questions, sir. Now I'll hand over the session to you for a thanksgiving note. Thank you, sir.
So I hope that the session was useful for most of you. And once again, I'd like to thank Ajanta Pharma Prisma Division for giving us an opportunity. The period of lockdown, we are finding it difficult to adjust, quite a few of us, because most of the doctors are used to rigorous lifestyles, working for at least 8 to 10 hours a day, and all of a sudden we have so much time. So it's a good measure by the industry, the pharmaceutical companies, surgical companies to start these webinars so that we can interact, share our knowledge, gain in academic sphere. If not, we are not able to do a lot of clinical work. Thank you very much.
Thank you, sir. Thank you.